So I'll present this case that we did about a week ago, and I think it is one of those ones that is complex, that requires thinking and strategy design before you actually start the case. It can be done in different ways, but this is the way we did it, and I'm curious to see my colleagues if you have any suggestions or if you would have done things in a different way. So 66-year-old female patient presented initially to an outside hospital in our community with unstable angina. Past medical history of diabetes, hypertension, dyslipidemia. She has been having progressive angina over the last 2 months. Now the angina happens even at rest. She's having claudication all the way up to the hips level. Her troponin is negative and no new ECG changes with normal ejection fraction on echo. So here is the cath. It doesn't show as well here, but on the big screen, it's actually the aorta is all calcified, almost like porcelain aorta. And you can see that the lesion in the RCA, sorry, I'll go back to that one, is mostly an ostial lesion causing severe like stenosis there that is heavily calcified. You can see it in different views here. The left system also had two other lesions. One of them is in the proximal to mid LAD, and the other one is in the circ. The circ one looked like almost like calcium nodule in the proximal part or close to the ostium of the circ. And the LAD had this severe calcified lesion in the proximal to mid part that also involved a bifurcation. So our colleagues in the outside hospital, they tried to do PCI, but they quickly failed. And looking at the picture, like using a JL guide and so on, like for such lesion, you really set up yourself for failure. It really needs so much planning and so on to actually succeed. The patient developed TIA immediately after cath. Symptoms quickly resolved. They did a scan and they found carotid artery stenosis bilateral. But neurology deemed that medical therapy will be best for this, and this is just mostly related to the procedure that was done. And the patient was sent to our hospital for CABG. So when she came to us with the claudication and vascular assessment, we did an aortogram, and essentially the aorta is completely occluded just below the renal artery. So this really adds an extra layer of complexity, because all of a sudden now you cannot use ECMO, you cannot use balloon pump, and in her case, to our surprise, also the left subclavian artery had severe narrowing at the ostium of it. So now we also cannot use Impella. So we had to think it through to decide what is the best way to do this procedure in a successful way if we are to do it with PCI. First of all, our surgical colleagues reviewed the case in details, and because of porcelain aorta, carotid stenosis, the occluded aorta, and all of that, they turned down the patient for surgery and advanced her for us for PCI. So we had to think it through and decide what is the best way to do this kind of procedure. Some of the main questions to ask yourself when you do such a procedure: do you do a atherectomy or not? Which device will work best for that kind of lesion you will deal with? Intracoronary imaging, IVUS, OCT, and mechanical support, and do you have a vascular access to actually do the mechanical support in case you need it? So this is the way we thought about doing this case, and we planned it all to be same sitting if possible, if everything goes per plan. So first of all, we wanted to obtain a left axillary access and stent the ostium of the subclavian artery, so that in case the patient starts spiraling down on us, then we at least can just put an Impella quickly, because otherwise with an occluded aorta, we have no other option to salvage the situation. And then stage 2 to do RCA atherectomy PCI, stage 3 circ and LAD PCI, and then percutaneously close the entry point of the axillary access. So we planned it that we do all of these stages during the same procedure if things go as per plan. So the first stage, using the left axillary access, some of the technical challenges that to explain for our colleagues here, we actually wanted to pre-close the entry point before we even do the PCI and so on. So that you can bear close at the end in a successful way. But the leading edge of the bear close, the black part that actually goes deeper than the suture itself, kept hitting that subclavian artery stenosis and did not go through. So we had to change plan, put the J-wire through, and then do the PCI itself, and then at the end of the procedure to do the bear close. Our vascular colleagues stented the subclavian artery here, as you can see. And then we started with the PCI. So for the RCA, we initially had tried different guides, AL1 and so on, but eventually nothing with the porcelain aorta, nothing was sitting in a nice way. It was either deep diving and damping or not engaging. So initially, at the end, we used, I think this was just a JR4 guide. A nice trick to use, I think, for ostial lesions is what we did in this case. We actually dynaglide kind of the orbital crown through the lesion, but did our orbital atherectomy backwards. I think this is safer for ostial lesions rather going like forward with the orbital atherectomy. Yep. So this is what we did, and you do it slowly. The other point here is usually we would consider a temporary pacemaker, but because the microcirculation effect of using orbital atherectomy is generally minimal, we find that mostly we don't end up using it. And in this case, we did the orbital atherectomy without temporary pacemaker, and we did not need it. But one key message here to get to the team is that we actually did the orbital backward to try to shave that ostium without the risk of going forward and then interfering with the aorta integrity and then having some kind of perforation or damage to the aorta there. So then, as my colleague Dr. Hani mentioned, even when you do orbital, still it needs work to actually prepare the lesion before you plant a stent. So here then we went with a cutting balloon, and we really had to hit it hard at the ostium. And then we went with 1-to-1 size NC balloons, and we made sure it is cracking very nicely before we actually started planning to stent. And then we tried to land the stent with probably one strut hanging back to the left main. And then we decided on imaging. So to be honest, IVUS would have been a very good option in this case, but for educational purposes, we chose to use OCT. And one trick also to highlight here is when you do OCT for ostial lesions, one of the tricks to use is to actually use a guide liner or a trap liner, engage the artery, and then do your picture, because around the trap liner, guide liner, you still can see that ostium of the vessel with very good opacification with contrast, which is what we did with this case. So the OCT run here, this is just a screenshot showing that we landed in an area that was good. There was no edge dissection. You'll start seeing the stent struts here. There was malopposition in different areas of the stent. And then it will show you when we reach the ostium. I just want to show how you show the guide around the guide liner. So when you do it with a guide liner, this is the guide liner. You still can see all the area around it. So this is a helpful trick for ostial lesions, as I mentioned. But as I mentioned, IVUS would have been a great tool in this case. So we went back with sizing based on OCT in the malopposed area, and we hit such areas hard, and then we'll oppose the stent throughout. And then we did our last angio of the right, looked very good. And then we shifted our attention to the left side. I don't know about you, but this is a situation where I would choose drug-coated balloon rather than stenting. Ostial lesion of the circ, where the left main itself looks very good. So that's what we did. But beside a DCB, we like to actually prepare the lesion very well, which is what we tried here. We went with cutting balloon, initially smaller size, then 1-to-1 size, and then use the DCB in that area. And you will never get a stent-like result when you do the angiogram. You'll always have that feeling, but as long as the flow is very good and so on, then it is very good to leave. But we had in our mind that in the future, if this area comes back with a stenosis and so on, then we can always convert it into a bifurcation PCI. And then we worked on the LAD, essentially with microcatheter, micro wire, and then we wired the artery, and then serial balloon dilatation. And to our surprise, it just opened very well, and then it looked good at the end. I just want to show you the final result if I can. Yeah, and that diagonal remained intact with very good flow with no issues. Then we reached the last stage of our procedure, is to actually do the pair close of the entry point to the axillary artery. Some teaching points here. Axillary artery, the wall of it is much softer than the femoral artery, and as most of you know, there is really no deep bone behind it that you can compress it against. So it is very important when you go with a pair close to have a stiff wire, get your pair close into the area, and then when you push the knot to push it really deep into the area, because generally it is almost 4 to 5 centimeters below the skin, because you go at an angle below the clavicle and obtain good hemostasis before you actually removing the stiff wire. And at the end, the patient did very well. Next day she went home and she's currently pain-free. But it really took a team, and it took our effort to try to design the case in a way that we do it in multiple stages, so we do it in the safest way possible for our patient. Thank you so much.